I'm Dr. Bob Horchover, and I'm here to introduce you to the Airway Metrics system. 16 years ago, when I started a limited dental sleep apnea practice, information guidelines and literature were very limited compared to today. 10 years ago, I added a pharyngometer in hopes it might improve my ability to predict treatment outcomes, but the traditional techniques for creating simulated mandibular positions remain time-consuming, so I began cutting small pieces of plastic to shorten and simplify the process. I now have 3 pharyngometers and over 6,000 scans. The system you are about to see represents 7 years of development, 2,500 pharyngometry scans, and each one of the patients had a diagnostic sleep study before they were referred to us, and after they received their devices they went back and had another diagnostic study to confirm the efficacy of the devices. I'll return shortly to describe each component of the system, the details of each component, their clinical application, and I have some closing comments. First, let's look at the entire system before I describe the components in detail. The cassette here houses the principal 2 segments of this. There are 15 mandibular positioning simulators, and they are arranged in rows from 4, 6, 8, 10, and 12 millimeters on the vertical plane, and these 3 columns allow AP positions at each one of these vertical planes. This column positions the incisors in 2 or 3 millimeters. This is end-to-end or 4 or 6 millimeters, and this is end-to-end or 5 to 7 millimeters. When the lower incisors are placed in the designated notches, that's how these different mandibular positions are simulated. The increments in here with these 15 pieces of plastic allow the mandible to be positioned in over 50 different positions from centric to plus 7 millimeters in the AP scale. However, using the Snore simulator, it defines the general area to be more carefully measured, and so rarely are more than 4 of those simulators required. The third component consists of 11 vertical titration keys for tuning an oral device, any oral device that can be opened in the anterior. And this tuning takes place at the end of the treatment titration towards the optimum airway. The numbers on the inside indicate the width of each of these. They function like a shim, and they are inserted in between the upper and the lower unit of the device. They can also be used as a stop for adding material to the pads if it's indicated that a better or an increased vertical would be more helpful. Now let's zoom in on each one of these components in more detail. Now for a close-up of the Snore screener. The bottom and wide end have a metric scale. The opposite end has steps at 4, 8, and 12 millimeters for vertical positioning in combination with whatever the selected AP or horizontal is, from centric to any selected position to maximum protrusive. And you can develop your own protocol at whatever increments that you want to set this. When you use the Snore screener, it is after you already have gone through your exam enough that you have the patient's mandibular range of motion. When the patient has produced a good snore sound, assign it a default number 5 level. I find that even those patients that have had UPPP surgery can make enough of a raspy sound that it can be quite useful as a measuring sound. With 5 as the base, insert the Snore screener between the incisors, for instance at 4 millimeters, that's the first level, at centric if you like, or end to end. And then have the patient snore and record on a scale of 5 to 0, 0 being no sound at all. And then have the patient slide forward, and you can check that at any AP position forward of centric. If you want to go halfway or all the way, you make your decision on this. After you've done the 4 millimeter position, then repeat that same process at 8 millimeters and 12 millimeters for each of those numbers. I describe this as a low-tech screener and a profound patient educator. The snore screener starts this process. When a robust snore screener goes instantly silent, you have their attention. The Snore Sound will identify the general AP and vertical jaw position and guide you to the simulators that you start with for more definitive testing. I prefer to hold the snore screener during the snore screening period and have the patient place their simulators as directed. The patient is very quick and accurate at doing this. Moving on to the next sequence as this process is performed, we're now back to the simulators. And on camera here, you're going to see an 8 and a 10 millimeter simulator, and you can see the number in a little circle in the upper left corner. Let's start with the 8 millimeter, which has 2 slots on the top and 1 on the bottom. And so that will be an 8 millimeter vertical opening, and either a 2 millimeter forward being forward of an end to end, or 3 millimeter forward, depending upon whether the 2 millimeter number is facing the patient or the 3 millimeter number. The 10 millimeter unit has 3 slots on the top and 1 on the bottom, so that this can be positioning in an end to end if the middle slot is used on the top. And if it is moved to the 4 millimeter facing the patient, it will be 4 and 10. If it's the 6 millimeter, it will be 6 and 10. There is a third column that has end to end as well. However, rather than 4 and 6 options, it has a 5 and a 7 millimeter option. The slot in each end of the simulators enables taking a bite registration in any one of the HV positions by simply inserting the special bite fork in one end and a handle in the opposite. The starting position may not necessarily be the position that is going to be the treatment target. I'd like to reemphasize at this point that airway change indicators can be the patient's subjective feedback or with pharyngometry. Airway Metrics system is a measuring system that works with any device and treatment protocol. Along with this, there are 4 different 3x4 pads that are used for entering this data. They're very straightforward, and they have a brief instruction pamphlet that goes with them. Now for the clinical application. I'm back in the clinic now with a long-time outstanding clinical associate of mine, Teresa Lyons, and we're going to go through the snore screening and the mandibular position simulation with a subjective feedback. So you've seen this in a larger format, which is the snore stimulator. And Teresa, we're going to put this in right between your front teeth, 4 millimeters, okay? And then let's slide your jaw forward, okay, and slide back. Okay, now just open, please. Patient gets a feel for how that is on the edges of their teeth. Now how about giving me a good snore sound for a baseline? Okay, how about giving me a better snore sound for a baseline? I know you're capable, that's better. Okay. We're at end to end, 4 millimeters. Would you snore, please? Okay, that is just a tiny bit better than that arbitrary 5 that we put on her natural snoring. Slide straight forward into protrusive. Okay. Okay, that's about a 3. We started with a 5, we're down to 3. This is where lesser is better. Okay, now let's go to the 8 millimeter, and she's at end to end at 8 millimeters. Go ahead. Okay, that's about a 4, all the way forward. Go. That's barely. So that's just about a 1 or a little less. And now just close. Okay, end to end at 8, 12. Okay, and slide all the way forward at 12. Okay, no snoring there. So Maximum forward at 8 millimeters, there's no snoring. Maximum forward at 6 millimeters, there's barely snoring. The snore screener has helped us narrow down the zone that we want to pay more careful attention to, and it's told us that at the 6 and 8 millimeter verticals, her airway opens more than when she is either in end-to-end all the way to max protrusive at 4 millimeters. So we're going to start with our mandibular position simulators at 6 millimeters. One nice thing about these little simulator pieces is that it's very easy for patients to put these in at the designated positions and be a participant in this, which I have found helps with their awareness and involves them more in the evaluation of their sleep apnea and what solutions may be best for them. So right now I have a simulator chip that has the end-to-end 4 and 6 millimeter, and I'm going to position this so that when this is turned around at the designated second notch, she's going to be end-to-end at 6 millimeters. Okay, now tell me how that's feeling for your airway. Just do a little breath on that.
That was about a 4.
About a 4, okay. And a 3 is going to be a natural airway, 4 is going to be better, 5 is even better, and then a 2 and a 1 are not so good, okay? So let's now go to the 6 millimeter, 2 millimeters forward. So now her mandible is 2 millimeters forward, and when I hand these to her, if the number 2 notch is pointing toward her, when she turns around and puts that into her mouth, she's going to be in 2 millimeter anterior. Okay, let's have a breath and tell us what you're feeling.
I would say that's a 5.
That's a 5, okay. 2-6 is a 5. Now we're going to go to 3-6. We've turned that around. She puts it in the same combination, reversed. 3-6.
That's a 5, but a little less uncomfortable.
A little less comfortable, okay. And now we're still at the 6, and we're going to come back to the first notch on the top, which will move her 4 millimeters anterior at 6 millimeters.
Did I do that right? No, I did not.
First notch on the top.
It's about a 4.
Okay. How's the comfort?
Comfort is less comfortable.
Less comfortable, okay. So the 2 and the 3-6 seems to be the best airway and within her comfort zone. So now let's go to the 8 millimeter vertical. Teresa, that first notch on the top will put you at a 2+ on the AP or the horizontal mode.
I would have to say that that's probably over a 5.
Over a 5, okay. Now we're 3 millimeters anterior.
That's probably about a 5, but a little less than that.
A little less. You like that first one, the 2 millimeters. So 2 millimeters horizontal, 8 millimeters vertical, so far is ahead. Now let's do the 8 millimeters, and would you go to the middle notch? So now she's end to end at 8 millimeters.
That's 5.
Okay.
And it's more comfortable.
Okay, now why don't you put that back in again, but put your upper incisors in the first notch. And now you are 4 millimeters anterior at 8 millimeters.
That would be the same,
Okay.
but less uncomfortable.
Not comfortable. Okay. So the end-to-end or 2 millimeters forward at 8 millimeters vertical or 6 millimeters vertical are both her better airways. It was evident from the mandibular positioning simulators that Teresa's comfort positions were at both 2 millimeters horizontal, 6 millimeters vertical, and 2 and 8. And so we're going to proceed to get the bite registration, and we're going to use an end-to-end 6 millimeters for the bite registration, and we will be connecting the forks and the handles to that mandibular positioning simulator to get our bite registration. Now we've decided that the end-to-end at 6 millimeter was the most comfortable and had the most significant change in your airway. So now we are going to get a bite registration, and I'm using the notches that I pointed out earlier at either end of this, and we're putting a bite fork in one side and a handle in the other, and now you can see that we have this ready to go. And so I will just fit this in on the middle notch on the top, and Teresa, close into that notch on the bottom. Bring your jaw back just a tiny bit and go right into place. Okay, now while I hold this gently against your front teeth, you only have to open it about 1/4 of an inch. Just sort of get so your jaw comfortably swings into that notch. Okay, and I'm going to be verifying that we're lined up in the center line by looking at the anterior surfaces of our incisors. And now we're ready to get the bite registration. So we're going to put the bite paste on the bite fork, but I do not cover the front area where her incisors fit in the notches, so I can have a clear view of the right-left alignment and her center line at all times when we're fitting this into place. Okay. Now, if I wasn't on camera, I'd be around there looking at that to verify it. So what I'm going to do now is just fill in this area right here. And now that I've already seen that we're centered right, I'm going to bring my material around, above and below. So now when this comes out, we're going to have an image. Just bring your lips around there, please. We're going to have an image of that center line in our impression material. And that's going to take about 1.5 minutes. And when we take that out, it's very easy to reconfirm once again that we're on the right-left midline. The nice thing about this system is I've used a George gauge for years, but we all know that a George gauge has a vertical alternative of 2 or 5 millimeters, and I spent a lot of time using light cure resin to change that vertical if I wanted it higher, more vertical. And in this way we just picked the mandibular positioning simulator that matches, or the ones that we got the best reference on, and put the bite fork and the handle on it, and we've already got our treatment bite. Okay, so now if we can bring this in close here. Now this is uncut, untrimmed, so the tooth notches and imprints in here are much more significant.